afternoon. So I'd like to move to the next session, which will be the last session for today. It is my great pleasure to introduce to you the world leaders in the field of inflammatory bowel disease. Professor Simon Travis, he's a leader in the field of gastroenterology, especially IBD. He's a professor of clinical gastroenterology at University of Oxford, UK, and previously he was a past president of the ECHO, European Crohn's Colitis Organization. He has received many international awards and prestigious lectureship in gastroenterology. So first, we will have him give us a lecture, which will be on a very interesting topic, especially common in Thailand as well, or in Asia, on acute severe ulcerative colitis. And after his lecture will be followed by our panel discussion. So please, Simon.
Thank you, Varocha. And I can't help but thinking, didn't we look so young in our photographs? But it's a pleasure and indeed an honor, and thank you for the invitation, and to Dr. Varocha and ASEAN for the invitation to return to Bangkok. Managing something close to my heart, which is that of patients hospitalized with severe colitis. I have one or two conflicts, but I think they all cancel out. Why does it matter? Well, it matters because acute severe colitis is associated with death, colectomy, and disease. Unless you think that death was yesterday's problem, let me take you through this. When Sidney Truelove, my predecessor in Oxford, did his first randomized controlled trial in gastroenterology using steroids, the mortality in the placebo group with acute severe colitis was 24%. In 2001, which is within all of our memories, there was an audit of a district general hospital just outside London, and the mortality then in that hospital was 24% because patients were admitted under a general physician, not a specialist gastroenterology. And then with a national audit, the mortality was almost 13% over a 3-year period after an episode of acute severe colitis. And that indicates that we should not just be looking at mortality on admission, we should be looking at the consequences of that patient over a period of time. And that's precisely what Massachusetts General Hospital in Boston did. Notice the date there, 2024, just published. Audit of patients admitted with acute severe colitis to the Mass General requiring IV steroids. The mortality, if you were 65 years or older, over a year after admission was 28%. It was still 1.6% at a younger age. And I must say, if I'm aged less than 65 and I have almost 2% mortality from a condition, that is a concern. Colectomy was the other thing that I mentioned, and these data are ones that I'll briefly come back to later, that our colectomy rate in Oxford from when we published back in 1996, which was 29%, has halved to our most recent assessment. So colectomy rate is going down as treatment options increase, and I will come explain why I think that is the case later. And then there is disease. Now, infectious diseases, you're all far more expert in treating gastrointestinal infections than I am, because you see so much more of it. There would be that the amoebae, the CMV, the C. diff, whatever. But work that I did with Vinita Huja, and I will comment on our collaboration with colleagues in New Delhi, not because, on a number of occasions, not because I think there's any relationship between South India and the Southeast Asian population, but because the collaboration has allowed us to look at acute severe colitis differently in a different population to that of most publications in the West. But what Vineet and colleagues found was that a high mucosal CMV concentration was associated with a very much higher risk of steroid failure. We're familiar with the higher risk of venous thromboembolism compared to other patients hospitalized with other conditions. And although the rate of thrombosis is said to be lower in the Southeast Asian population, I bet that acute severe colitis increases the risk in that population. And you only need to die once from a pulmonary embolus for it to be a terminal event. You only die once. And drug-induced adverse events, we'll come back to some of those in a little bit. So how do we recognize it? And I make no apologies for putting up true love and wits criteria, which should be ingrained into your thought as a young doctor. But they are clinical criteria, and the reason for putting them up is as much to point out how modest they are. That we will all see patients in our clinic who've got bloody diarrhea 6 or more times a day. But if they've got a bit of a tachycardia or a temperature, or they're anemic, or they've got elevated inflammatory markers, which of course you can't get back when you see them in the clinic, that characterizes those patients with acute severe colitis. And it's very easy to think, oh, well, gosh, no, it's difficult to admit them to hospital, then we will just treat them as an outpatient. These criteria were questioned in India, and they reassessed and found that in an Indian population, that the hemoglobin they felt was not relevant to their population, not least because many Indians have a chronically low hemoglobin. But I think that the objective criteria is what Sydney Truelove just there were the clinically relevant, which you can apply in outpatients, because we don't necessarily know when our patients are sick. It's very easy to underestimate them, and I still apply those criteria. And it's the reason it's easy to underestimate the severity because many have been on steroids, patients play down their symptoms, and we as doctors don't want it to be to make a diagnosis or a condition which has implications as far as admissions and poorer outcomes. But if you delay the diagnosis, if you delay the recognition of acute severe colitis, that increases the adverse outcome, be that colectomy or mortality. And of course, the first presentation, if you have an index presentation of acute severe colitis, it's too easy to imagine, oh, it's all infection. I see my infectious diseases colleagues do this in Oxford still to this day. When somebody comes in with bloody diarrhea, they wait 4 days until cultures come back before they say it's definitely not infection. And if you apply these criteria, you can identify those at highest risk of colectomy. You only need one of these additional criteria in addition to a bloody stool frequency of 6 or more times daily to have a really quite appreciable colectomy rate. If you've only got one, so we say you've got a tachycardia, it's a 9% colectomy rate. And that's on the index of admission. If it's 2, 3, or 4, it goes up to 31 and then almost to 50%. So those are serious numbers, and that's why I justify admitting our patients for treatment. Of course, you need to do a range of tests, but I think keep it simple. PCR is widely available now, although expensive. Also send off a C. diff assay. Full blood count, CRP are the key things because the CRP has prognostic value. Do a plain film, and yes, do a flexi, and impart so that you can get tissue to determine whether there is active CMV tissue disease. Here in Thailand, you've got to be looking for amoebae. You'll be very experienced with this. When I saw a case in Oxford, a young lady who had been to Bangladesh 4 years previously, I'm afraid we missed the diagnosis until she was about to have a colectomy. Fortunately, we found it in time. But use one of the published indices for judging the severity and the likely response to steroids and the likely outcome. There are two indices. There's the AIMS index from India and also the newer Admit ASG index for predicting response to steroids. And then there's the familiar Oxford Third Day Index for predicting the response to colectomy. The AIMS index combines the endoscopic severity and the fecal calprotectin with high specificity, not very good sensitivity for predicting failure of response to steroids. It's all about preparing the mind for what you expect and managing the expectations. The expectations not only of the patient, but the expectations of yourself as the physician, and perhaps even more importantly, the expectations of the family of the patient, because they're very much part of the decision-making. What we published last year in Gut was the Admit ASG index, which combined the CRP, albumin, and UCIS with very high specificity for predicting steroid response, and where 1 point is given for each criterion. The limiting factor there is the CRP has to be very high in order to get a single point, but otherwise it has very good predictive value. And I'll show you the data here, pointing out that we did the discovery cohort in Oxford, we validated it on the Gold Coast in Australia, and then again also at AIMS in New Delhi. And you can see that if the patient, when they are admitted, have a score of 4 out of 4, that means very high CRP, low albumin, high UCIS, then they have no chance of responding to steroids. It's slightly, even if they've got 3 out of 4, then the chance of responding to steroids is extremely low. Just a couple of clinical points on a plain abdominal film, because it seems not to be taught these days, and you don't expect a radiologist to report a film with picking out these features, because they just don't, even the specialist GI radiologist. But the first thing to look is for the mucosal edema, and you can see the very, very thick colon just up there. You measure the colonic diameter. If it's more than 5.5 centimeters or more than 6 centimeters external diameter, then there's dilation, but you do need to measure it rather than just applying the Mark 1 eyeball. And then also take a quick look at the distal distribution of fecal residue, because the distal distribution of fecal residue roughly approximates to the proximal extent of disease. And it's very clear this patient has got a pancolitis. If you're doing an endoscopy, the UCIS does have prognostic value, and the UCIS, to my mind, is simple to apply, because it only requires you to look at the vascular pattern, the bleeding and erosions and ulcers. Even surgeons use it in Oxford, not because I encourage them to, because they realize that we all ought to be speaking the same language. And the sigmoidoscopy, which is done unprepared, flexible sigmoidoscopy, not a full colonoscopy, please. Full colonoscopy in acute severe colitis is potentially dangerous. Then you can take biopsies and check for CMV. But the key thing about UCIs as opposed to the Mayo is that it accounts for 88% of the variance between observers, and that actually matters. we showed with Crispin Court, who's now back in Sydney, showed that if the UCIS was very high, that's 7 or 8 out of 8, then almost all came to rescue therapy or colectomy. And so I think the endoscopic severity alone has a predictive value, but you can augment it, as I indicated, with the biochemistry of the albumin and CRP. We're all familiar with the standard treatment of steroids. I wouldn't normally give antibiotics in the UK. Here in Thailand, I think that it's very reasonable to do so because infection as a precipitant of acute severe colitis must be so common. And then I would opt in general for a quinolone. Watch for the magnesium, which can drop as well as the potassium. Give them thromboprophylaxis because of the risk. And nowadays, I believe you should augment that with exclusive enteral nutrition. And the reason for that comes down to this controlled study, which we performed in New Delhi, which was an open-label study of patients. Everybody received the standard intravenous steroids, but then they were randomized. You couldn't blind it. They were randomized. One group received exclusive enteral nutrition as well, not with a nasogastric tube, but actually just drinking the enteral nutrition. And you can see that the response rate just missed the statistical significance on the ITT, although met it on the protocol. That analysis was significantly better than those who just read steroids alone. In fact, it also showed that the relapse rate was lower, and the 6-month colectomy rate was lower in the people who received exclusive enteral nutrition. So it seems to be related to the microbiota, Ratakon, which we publish separately. And then, yes, you need to ask the patient to record their stool frequency because that has predictive value, which together with the CRP can be applied at the bedside, that if on the 3rd day of treatment with intravenous steroids, that the stool frequency above 8 or the CRP is above 45 with a stool frequency of between 3 and 8 a day, then almost all patients will come to colectomy on that admission. Those data go back to 25 years, but on the other hand, they act as a threshold for starting rescue therapy. And I think that's the key message in 2025, that we need to reduce the threshold for starting rescue therapy, because you need to make those decisions. If people meet those criteria on the 3rd day of treatment, you need to talk with the patient and the family. You need to start rescue therapy, and you need, in my view, to call the surgeons as a contingency. Because colectomy saves lives. No patient wants a colectomy, but you've got to make contingency plans in case. You need to have that discussion, because trying to have that discussion when a colectomy is inevitable to save the life of a patient is far too late, because there's always a temptation to kick the can down the road. And in the past, it's been a question of rescue therapy. Do you use infliximab or cyclosporin? I'll briefly show you the data, but to be honest with you, I think that now it's a question of whether you use infliximab or tofacitinib. And these are the data I previously showed you, that the colectomy rate, these in the red bars, since 1996 in Oxford, have halved. But what's happened is that in the past 25 years, our use of rescue therapy has doubled. And I'm sure that sends a message. And so we're using rescue therapy in over half of our patients with ulcerative colitis, not with acute severe colitis, not because I think the disease got any more severe. It's just our thresholds have reduced, and I think that's an important message. We use cyclosporin or infliximab. We don't use tofacitinib. The the reason for advising tofacitinib is as much for availability and convenience as opposed to cyclosporine. There have been randomized controlled trials, 2 randomized controlled trials comparing infliximab and cyclosporine, and one was from the French Jeté group, another was from the UK group, and the sample sizes were reasonable, 115 in the Jeté, 270 in the UK side, and the primary outcomes were no different. Here is the treatment failure was the primary outcome in the Jeté group, with cyclosporine and infliximab both being similar. And when David Lahari went and followed up all of those patients over the course of 7 years, you can see there's absolutely not a widgeon of difference between infliximab and cyclosporine, and nor indeed when you looked at the primary outcome from the UK construct style, and this is looking at quality of life, you can see that whether people received infliximab or cyclosporine, there's absolutely no difference. Interestingly, on the follow-up, in the construct study, there were 3 patients who died, and all of those were in the infliximab group. None of those patients receiving cyclosporine at 2 milligrams a kilogram would actually died. But lest you think that is significant, look at the Pisespongsa study where 3 patients also died, all of them in the cyclosporine group. So it's a dangerous condition, and I mentioned that you only die once. Some people are advocating just give more and more infliximab, but in this systematic review, 7 studies, there were no difference whether people received high-dose infliximab, 10 milligrams a kilogram, or frequent dosing for regarding colectomy at 3, 6, 12, or 24 months. And I believe that if you're going to use infliximab, you use it and you use a standard induction, and rather than keep on multiple dosing. I know their opinion differs on that, but that's what the evidence supports. Tofacitinib I mentioned, not least because of its availability and also for the generic tofacitinib, which is widely available. It's extremely cost-effective compared even to biosimilar infliximab. There is the whole range of studies and case reports with which have been reported, but there's not been any randomized controlled trial. The simple message seems to be that high-dose tofacitinib, that's 30 milligrams daily, is effective for treating patients who are not responding to steroids. Remember, make that decision at the 3rd day. But be aware that although it has short-term efficacy with with 85% avoiding colectomy over the course of a month, then there is still a risk of zoster, and we need a randomized controlled trial. I keep on going back about the timing of decision making, and these Canadian data illustrate why. That if you look at the mortality there in the top right, you can see that the longer the length of stay in hospital before colectomy, the higher the mortality, the higher the morbidity, both of them reaching significance if you've been 7 days in hospital on medical treatment before colectomy. And yes, there's no doubt that the outcomes are better if you're in a high-volume hospital. So after you've successfully treated the patient, then you need to have effective maintenance therapy. I favor of tofacitinib because it's my belief is that it's safer and more effective than azathioprine. In the past, we used to use azathioprine. Clearly, if you used infliximab as rescue therapy, that had best continue, despite the cost implications. But I think that if you're going to use infliximab as maintenance therapy, you're going to have to use azathioprine as well. And I disagree dislike azathioprine, although in a South Asian population, then it seems to be safe with no cases of lymphoma or non-melanoma skin cancer, despite the reports in the West. Tofacitinib, on the other hand, whilst it's associated with an increase in zoster, is better tolerated and I think likely to be more effective than azathioprine, although we haven't had any comparative data. So, just to conclude, I'm sorry that this is barely legible, but it is an algorithm which Vip Jairath published in just earlier on this year, that when patients come into hospital, you recognize acute severe colitis and remember those criteria, apply them in your practice, then you estimate the likelihood of response and use the admit ASC index or just count the number of true love and wits criteria. Give them intravenous steroids together with enteral nutrition, and you judge their response to that on the third day. And you have a couple of days, perhaps I would make a decision on the third day, to decide whether you're going to give rescue therapy or not. Have a low threshold for rescue therapy if there has not been a complete response to steroids, and then infliximab, cyclosporin, or tofacitinib. And if there's a response to that, that's fine, you continue. If there's no response, that is when you have, the patient should have a colectomy. Don't try and use another form of rescue therapy. Don't try and rescue the rescuer. And that really is the concluding message. Recognize the condition. Yes, be aware of infection, but treat both rather than either alone. Use objective criteria, biochemical and the endoscopic in addition to the clinical criteria, because this predicts the risk of surgery and likelihood of response to steroids. Monitor stool frequency and CRP, which give you a signpost of the decision-making on the third day, but you've got to act on those day 3 criteria. You need to prepare the patient in case of failure, so you call the surgeons in as a contingency, but it's only a contingency. You start either tofacitinib or infliximab, but please don't use both alone. Please don't use both one after the other. Much safer to go for colectomy if one of those has failed. And if you're in doubt, don't duck a difficult decision. Call a friend, because they are only a phone call away, and your patient will benefit. Thank you very much indeed.
Thank you. We keep Q&A at the end. I'd like to invite the other 2 members, Dr. Pises and Dr. Arti, to join the panel discussion. They're here. Excellent talk.
Even you look younger, Pises.
I try to find the best picture.
Right, yeah, indeed, yeah. Well, I spent a lot of time looking as well. Yep.
Okay. Thank you, Professor Varocha, for your kind introduction, and it's a pleasure to join the Acute Colitis Professor Travis, because it's the 100th lecture you must heard before you die as a GI doctor. So the case discussion is 56 years old English gentleman. He's working in Sri Lanka. He had severe bloody diarrhea and fatigue for more than 1 month. 4 years ago, he had chronic diarrhea and abdominal pain. Colonoscopy in Sri Lanka showed that he had ulcerative colitis, and he was doing well with mesalamine 400 milligram 2 tablets twice a day. In January 2020, he started having bloody diarrhea 6 to 10 times per day. His smoking dropped from 14 to 12.7 grams per deciliter. CRT was up to 35 grams per liter. Colonoscopy was done and showed that he had severe pancolitis. His daughter start prednisolone 40 mg per day and add mesalamine 1 gram suppository twice a day. This is the colonoscopy in Sri Lanka.
Can I put my hand up? Go back. Yeah. So I just want to make 3 points.
Sorry.
First of all, okay. First of all, not all Englishmen are gentlemen. Secondly, what did I say about the temptation of treating patients with acute severe colitis as outpatients? Here is clearly meets the criteria for acute severe colitis. We don't know what his pulse rate or temperature was, but his CRP is 35, and roughly a CRP, I mentioned ESR, but CRP over 30 still applies. But this patient's got nasty disease, and he was treated as an outpatient, and I would be, there's an opportunity missed there.
Yeah, I mean, I would agree with what Professor Travis said, because according to True Love, which criteria that would go into moderate severe. So I think for me, I think mesalamine, I think it has a role in a severe, moderate to severe ulcerative colitis.
Yeah. But what were they doing using that pathetic dose of mesalazine, 800 milligrams twice daily? We won't get into that, and I wouldn't have bothered giving it a topical mesalazine. Anyway, isn't it easy to criticize somebody else's management? Yeah.
Okay, and this is the colonoscopy at that time. You can see some bleeding inside and erosion. At that time, his symptoms are not better, but CRP was reduced to 22. The doctor started infliximab 400 mg IV on 4th and 18th of February. However, he still have a lot of symptoms, so he flew to visit us. At the time, he was still using prednisolone 20 mg per day. He still have diarrhea more than 20 times per day, and his bloody in more than 50%. He said it's a terrible fly to Bangkok. He was very fatigued and lost weight from 87 to 33 kilo in 2 months. His temperature was only 36.9. The pulse rate was 71, but he stated that normally it had never been more than 50 because he exercised regularly. And his hemoglobin was dropped to 10.8, CRP was 16.3, and ESR 52.
March 2020 was not a happy time of year to be time to be unwell at all, was it?
Yeah, that's right. So what is your opinion? Is this do you think it's severe?
Oh, I mean, he meets the criteria for acute severe colitis period even then, and even more so. So he's not only steroid dependent, he's steroid refractory, because he's made a bit he's been on steroids a long time, and he's got worse. And he has, he's also seems to be anti-TNF refractory, which is he's had 2 doses but is still unwell.
Yeah, I mean, this is not acute severe UC with partial treatment for sure, because he was put on steroids, but then the symptoms in March 2020 were clearly worse from before, with increased diarrhea and worsening hemoglobin and symptoms. So yeah, I think he's refractory on steroids.
Okay. So this is the criteria that Dr. Travis showed us. So Arti, what intervention should we do for now?
We should do the basic workup. I think the labs, some of the labs have been sent, including CBC. I think albumin is another useful one to do, because it's a good predictor of the severity of the disease and increased hospital stay. Other things which is sent include CRP, stool fecal calprotectin, and rule out infection, so stool cultures, C. diff, and I think what Professor Travis mentioned in his talk just now, we should consider doing a we need to work. This is severe UC, but potentially the patient may need a biologic, so we have to do workup for biologic, including sending hepatitis B, C, HIV serologies, TB quantiferin, do a chest X-ray, as well as doing an abdominal X-ray to rule out complications such as toxic megacolon, and also it would be good to see the severity of the endoscopically, and also to rule out CMV. So do a flexic but not a full colonoscopy because of the potential danger of perforation of doing a full colonoscopy.
Agree.
Yeah, in the time I should have attended his lecture before. I took the picture of your slide, so next time I can do better. Okay, so the liver function test seemed to be okay, just a bit low albumin, hepatitis B and C were negative. The renal functions looked okay. The person is a bit okay, surprisingly with the 20 times diarrhea, but he take a lot of oral rehydrating salt. The iron study was a bit low. Just was unremarkable. Quantiferon TB were negative. These two exams show a lot of white blood cell, was few red blood cell, fecal coagulopathy more than 3,000. The GPP GI pathogen panel PCR show enteropathogenic E. coli and enteroadhesive E. coli. The culture later was negative. C. difficile toxin and toxin B gene PCR were negative. And we do the X-ray. Do you have any comment?
No, it's a gassy film, but and I wouldn't formally measure the diameter of that transverse colon, but yes, it just looks less than 5.5 centimeters. So he's got a pancolitis. It would fit, especially if he's got infection as well as acute severe colitis. And I think this is a real challenge, isn't it? It's not just infection, or I think it's both.
Okay, so and we do sigmoidoscopy upon Dr. Arti request. So could you please tell us about the finding?
So this was a full colonoscopy, or it was just done?
Sorry, we did just the sigmoidoscopy. Just up to the upper sigmoid colon and the lower part.
Yeah, so the scoring system, I'm used to scoring determining the severity of ulcerative colitis. There's the Mayo score for assessment of ulcerative colitis, because it takes into account endoscopic findings as well as clinical symptoms such as the severity of diarrhea, the amount of blood, and the physician's subjective assessment of how severe the disease is. So looking at the endoscopy, I think that clear deep ulcerations with some, you can see a little bit of blood friability. So for me, on the Mayo score, that's definitely a 3. And given the number of the diarrhea and the amount of blood seen, and my subjective assessment of how severe it is, I think this would fall under acute severe ulcerative colitis.
Yeah, I just, you need a little bit more training, I think, about get used to using the UCIS. So vascular pattern absent. There's 1 or 2 specks of blood, so that's B1, so V2, B1, and you reckon that that's a deep ulcer, and I probably agree with you, because the difference between a superficial ulcer and a deep ulcer is whether the edges are raised. So in a deep ulcer, the edges are raised. In a superficial ulcer, it's not. And if you look at one of the ulcers a little bit on, you can see the slightly raised edges. So I would call this V2, B1, U3, which is 6 out of 8. And it's that which has been validated or is being used to have predictive value.
So according to Professor Travis, you think it's V1?
Superficial, okay. I mean, I agree that it's debatable, but yeah.
So because otherwise I need to have training from you again.
V2, B1, U2, which is, that's 5 out of 8. I have to say, I think it's more, I reckon those ulcers might have been classified as deep ulcers, but I think that the the thing about the Mayo score is the Mayo Clinic score is that there's overlap between the criteria, the descriptions. There's overlap. Whereas the UCIS, the descriptors, the definitions are very precise. The second point is that when everybody remembers, the only thing they remember about the Mayo score for endoscopy is that it's 0, 1, 2, or 3. Anything which is ulcerated is 3. But in fact, what people do is they separate it just on assessment into quarters. They don't actually remember the precise definitions there. So I think that, and of course I'm an advocate for the UCIS, but leave that apart. It's consistency among practice. That's what I like about it. And the granularity of a 9-point scale, that's 0 to 8. The 9-point scale is, I think, better at detecting change than a 4-point scale of 0 to 3. But let's carry on.
Thank you, sir. Because he is the one who described it and give a lecture around the world. So I think it's good to learn from him again. Okay, so next is the treatment. We start with the younger doctor first.
So because the stool cultures show that the infection was positive, so I think for E. coli, and so we definitely should start antibiotics such as a quinolone, as Professor Travis mentioned, is a good choice. But at the same time, because we are worried about severe UC, and do we treat the infection first or wait before starting immunosuppression? Because giving immunosuppression would potentially could worsen the infection. But I think in this case, I suspect there's a severe UC process going on as well as infection. So delaying starting the steroids would be potentially risky, and so I would start antibiotics as well as IV steroids at the same time.
Yeah, I'm sure that's right. It just occurs to me, though, that and you can educate me, that he's got E. coli infection, but is it the enterotoxigenic E. coli which tends to cause a right-sided colitis? Is that with proximal coli? Whereas clearly he's got distal, is clearly very active distally, so I'm sure he has got both infection and bad UC as well. So I'm sure it's right to continue to give both.
Okay, so I agree. So because in the first place, at that time we don't have your admit US AST score.
No, it was published in April, and this patient was admitted in March, I noticed.
Yeah, but when we have so severe patients, sometimes we need to call the surgeon in the first place. We are not lucky at that time, we don't have this score. Okay, so we start
But he scores 3 out. If you go back.
Yes, sir.
So he scores. Scores 2, doesn't he? That's interesting. So his CRP is not over 100. His albumin.
2.9.
Oh gosh, it's 2.9.
So
oh gosh, yes, indeed. And so actually only 1. So he should be potentially responding if it's only 1 out of all. Well, anyway, that's interesting.
It's easier to look back. Okay. So we start dexamethasone because at the time when he came on it, he said he cannot stay in hospital. He need to do a lot of things because he just arrived. So we start dexamethasone 10 milligram, which is equivalent to methylmethasone 53 milligram. And at the time, we don't have the data from India, but basically I think we extrapolate from the Crohn's disease trial. When the disease is very severe, we ask him to go on only enteral nutrition, and we discontinue methylamine. What do you think about methylamine? Do you want to stop, Dr. Arti?
Yeah. As I mentioned, in the case of severe UC, I think from studies, methylamine has been shown not to be effective, especially when you're going to require IV steroids. So for me, I would stop. But I've seen cases in practice where the physician has decides to continue it as well. What was your opinion on this, Professor Travis?
Sorry, I didn't quite get the echo. Then was what were you saying?
No, I was saying for me, I would discontinue mesalazine because,
Oh gosh,
because
and
in
how?
the case of severe...
completely. No, I
yeah.
completely agree with all that. The type of steroid doesn't make any difference at all. Dan Turner showed that back 15 years ago, looking at the outcome of acute severe colitis. Whatever steroid you choose to use is effective there. So I agree with that. It's I would have chosen equinolone rather than ceftriaxone, but that's by the by. And I'm glad that you felt it appropriate to give intravenous iron because I think that treating the patient when they're anemic, iron deficient, I think is important.
Dr. Arti, for me, I'm a bit racist. Because he is Caucasian, I give heparin. But for Thai patients...
You wouldn't have done. So that's interesting. You need a study. I really do believe this, that in, and they're doing it in Delhi at the moment. I really do think that you ought to look at the venous thromboembolism rate in the Thai Southeast Asian population. I know it's said to be lower, but I'm sure that it's increased compared to the others. And remember that with acute severe colitis, the thrombophilic or prothrombotic tendency lasts 6 weeks after discharge. We've just published that in CGH a couple of months ago from work we did a number of years ago in Oxford, and I think it's a real issue. So I do think you ought to, if there's any way of tracking records, you ought to check.
Yeah, I agree. We should, especially if they're admitted to hospital, we should always start thromboprophylaxis.
But sometimes it's very difficult to tell the patient we have bleeding to have the heparin.
Oh, come on. No, it's only a prophylactic. And anyway, if you even fully anticoagulate them with heparin, you're too young to remember. But back in Varocha and I remember when heparin was being used for treating colitis, there were 3 studies and actual formal anticoagulation. So no, it's not an issue at all.
Okay. But this patient is very nice when we're talking about the risk. It's okay to use that. Okay. After a few days, in fact, after 1-2 days, the PCR CMV was positive. And after 3 days, we got the histology result. We haven't seen any inclusion body, but the immunohistochemical study for CMV was positive.
Yeah. So tell me, Pises, does one swallow make a summer? That's what we say in the UK. So swallows come in the summer. To the UK, having overwintered in Africa, and we say that does one swallow make a summer? The answer is no. Just one swallow doesn't mean to say that summer's arrived. Just because you see one Alzheimer's inclusion body, that doesn't mean that you've got serious tissue infection. CMV tissue infection is usually characterized by high fever as well. So I must say. Okay, he's previously had CMV, he's 56, so is that a surprise? So his PCR is going to be positive. I wouldn't treat CMV in this patient. You've already got one infection, so I must say I wouldn't give him valganciclovir. But you're working in the Southeast Asia, and I'd be interested to know whether you did.
Well, I mean, Professor Travis is way more experienced than me, but for me, seeing tissue CMV positive, I would be on the side of caution and give. I'll consult infectious disease and see what they think, and maybe give.
Good. I'm glad you said that, because that's absolutely the time for a call and speak to the because and we would routinely do that. We have to go through. We want to, but equally. You could be the devil's advocate and say, well, this guy's in trouble. He's got steroid-dependent anti-TNF refractory pancolitis, maybe set to lose his colon. Let's treat everything which is possible. I think that this is this case where you would really have a multidisciplinary discussion and talk and then make a decision. Okay.
Fortunately, because when we got the CMV result, the patient feeling better, so we didn't treat him at that time. The diarrhea reduced to 6 to 8 times with normal blood. The CRP reduced and ESR reduced. Hemoglobin was a bit increased after, I think maybe from the inflammation reduction rather than just solely the iron supplement. We do the stool examination. We have less white blood cell, but we haven't done fecal calprotectin. I don't know that is very useful.
So what? So how? I mean, I know the Ames index advises
I just
fecal
know that we
calprotectin
can
and tracking that down. I must say, we tend not to, and I tease Vanita Huger about that because he's always doing it. Can you use it for tracking? Possibly. I usually, because it takes about 3 or 4 days for a result to come back, it's usually sort of, it's not relevant on the day.
It's 1 day.
Oh, I see. Well, you're very efficient. I mean, it certainly isn't 1 day with us, it's 3 days. So you can track progress, though. I grant you that. We don't actually measure stool red cell count or white cell count, but that's interesting. You can see things are improving.
And
Yeah.
do you recommend to measure?
Do I measure?
So fecal calpro after treatment?
I measure CalPro if for its negative predictive value, which is so if it's normal, whatever normal is, then that is helpful. And if I want to avoid doing an invasive procedure like a colonoscopy, so we don't track it routinely, religiously. I do believe you can practice gastroenterology and IBD without having to go to fecal calprotectin. I also believe that fecal calprotectin is today's best biomarker, but in 3 or 4 years, there'll be far better biomarkers and we won't be using it. Anyway, that's just a personal opinion.
I'm not sure that there's a clear correlation with how high fecal calprotectin is and the disease severity. But for me, I would get one at the beginning just to confirm there's inflammatory process going on, but not I wouldn't routinely use it to monitor progress. Maybe I'll do one after the patient clinically is recovered to make sure that it becomes normalized.
Yes. How long should we continue steroid?
5 days max.
5 days
Max.
max.
Yeah, 5 days max. But I would use the Oxford criteria that Professor Travis mentioned.
Yeah, we follow
day 3.
your Oxford criteria. At 3 days, you feel better, but there's also the UK study, right?
Yeah, there's Chris
guideline.
Lamb and colleagues, and it's you've done well to reproduce it so clearly, but it's an appropriate approach. They use slightly longer than I would accept, but it's reasonable.
Yeah. So, but anyway, because on next 3 days, he need to fly back to Sri Lanka, so we switch to the oral steroid on the 5 day. Last question is, was it appropriate maintenance therapy for this patient?
Well, you've treated infection. You've given him anti-TNF therapy. I'd be inclined to continue anti-TNF therapy, and then have a discussion at a later. I mean, he ought also to be on azathioprine, but as I said, I would have a low threshold for switching him to a JAK inhibitor, as long as he had been vaccinated against shingles.
I agree with that because he's been induced with infliximab, so naturally it would make sense to continue infliximab. But it depends on many factors what the maintenance is. It could depends on which country you're practicing in, because if you're limited by the insurance, for example, in Thailand, infliximab was only covered this year, a few months ago actually, on the universal healthcare coverage before. If they can afford it, they'll have to go on thiopurines,
indeed. I mean, that's encouraging to know. The thing is that if you have an episode of acute severe colitis and you avoid colectomy, there's a 32, call it a third will be readmitted in another occasion. I wouldn't trust mesalazine at all. I don't believe that mesalazine has a
Colectomy sparing?
no, I don't think it is. it has a chemopreventative effect against cancer other than by reducing inflammation. Any reduction in inflammation will have a chemopreventative effect. And so I would say there's a strong indication for continuing infliximab. You can always suggest that instead of going back to Sri Lanka, all he had to do was to go back to London and get infliximab for free anyway.
Yes. One of my patients, he went back to UK and he got free biologics.
Yeah, well, it is, but all treatment.
And they even send him to Thailand, the medicine. just we need to send the lab back to UK and they will send medicine to Thailand. Okay. So this case, we continue the infliximab for him and he's doing well after that. Okay. Thank you for your attention. And thank you
for sharing it.
Professor
It's great fun. Thank you.
you.
Bye-bye.
Thank you for the panel member to make the case discussion very interesting. So I guess it's time for closing for today, and we meet again tomorrow.
Thank you for our exceptional speakers and moderators for such a fascinating session.